Next speaker is Dr. Chow, who is going to speak about a stretched situation. So if everybody agrees, we try to keep it interactive, not one long lecture and then, but maybe discuss throughout the cases more interactive. Yeah.
Good morning, Chairman. Good morning, colleague. I'm Dr. Châu Đỗ Trường Song from Gia Đình Hospital. Today, I would like to present a complication case, a stretch situation. Maybe this is a very long story. And I will start my case. This is a 51 years old businessman. He admitted to our hospital for the second BCI. 1 month before, the patient admitted with inferior STEMI, and he was treated with 1 year on the ICA. And this time, he come back with the stage BCI left main LAD. And this case is not so normal. Cardiac echo is LVEF around 46%. And this is the picture of the left main LAD. And we plan to do the BCI on left main LAD. The surf is quite small in this case. And as usual, we do the NC30 by 15 along the left main to LAD. And this is the angio and the IVUS. Excuse me? Cho hình chạy. The IVUS run is a bit quite long, but it's maybe some new arteriosclerosis and no, not so much calcified, just some calcified at some point at the proximal of LAD with a 180 degree and some plaque on the left main. And so that's why we proceed and we implant one stent, long stent from left main to LAD. This is the IVUS run. It's not so severe calcified. So within just normal BCI, so we proceed with the stent. And we put a long stent 30 by 48 from posterior left main to mid LAD. And this is the picture after stenting. And then we decided to use a NC balloon along the stent. And at this point, I see that at the proximal of the LAD, the stent is still not well expanded. So we started another post NC. And at this point, after deflated the balloon, I cannot retrieve the balloon. It's stuck. It's so strange. We do not, anything happen. And so after many times, I try to pull back the balloon very, very strong, forcefully. and luckily that balloon go out. And then we check the stand, and we see that there is still not well expanded from distal left main to the proximal of LAD. Maybe that we put the stand look well open, but here we can see that the stand is not so good, and so we decided to both dilate with a balloon, but with an NC40. But it's very strange that we cannot insert any balloon. It's
Okay.
still stuck at the tip of the catheter.
Some people have some ideas. Do you have like the stent boost or the clear stent to see? You see
No, at
don't
this
have the
point,
system?
we don't check.
Okay.
We just
Okay.
feel so strange that
Okay.
we stuck at any balloon at the tip of the catheter, like hitting a wall.
Oh.
We don't know what happened.
Some people have some idea in the room.
And the basin is still
Still fine?
okay.
Okay. Any suggestion in the room?
And
Probably most
other
likely it's a
view.
compression, longitudinal compression, because once you pull hard, we didn't see the catheter jumping in, and that's probably my first thought when you cannot put it in.
Sorry. And at this point, we try to see without contrast, and we put back the catheter out of the ostium. And then we think that, sorry, we pull out the stent.
We can see
We
it.
pull
Yeah.
out the stent out
Oh.
of the ostium, so it's come into the aorta. This is what we see, what we think, and so at this point, is unfortunately that we lost the wire. Really. So at this point, we very embarrassed, and in this case, we think about 3 options. Let's try to rewind to proceed the procedure. The second thing is to stop a medical treatment because there is no dissection. And secondly, we send for the surgeon for cabbage.
Or number 4 would be to snare out the stent first with the safety wire and try to pull out the stent. Yeah. Who would try to pull out the stent? Who would be so crazy like me? Yeah. It's easy, probably. Yeah. Yeah. It's not complicated. The Hong Kong guys agree with me. That's good. Thank you, guys. Some other opinions? What does the Japanese doctor think? What the Japanese style? Would you also put out the stent, or do something else? Use the microphone. Yeah.
So in this case, maybe I'm going to just try to redirect another wire to main 30, then check IBUS. I don't know how much the length of the stent is coming to the aorta. So always in our practice, the IBUS is the first. So we have to know the situation exactly. So the IBUS is very useful. So always we try the IBUS. So before IBUS, we need to revise.
Okay, yeah. That's good. Maybe one short Thailand opinion and then one Singapore opinion. Yeah, in Han. Yeah. Dr. Viraj maybe ask. Yeah.
I think in this situation, I will try to wire first,
Okay.
and then try to use some balloon catheter to test that it is possible to push this balloon inside your abdomen. Because now I think in case that there are some stent fracture or distortion, and you try to pass the guide wire, it's a possibility to come to go outside the stent. And my hypothesis for this case is that this is my own theory.
Okay.
You do a lot of post-derogation. The more post-derogation, you will cause the longer stent elongation. And then some part of the stent will protrude outside the abdomen. And while you try to push the the guiding catheter again, the abdomen to pull the catheter out. sometimes it encaps this protrusion
Yeah,
frequent
probably.
and put it together.
Inhan, you other opinion?
I've got a question down this end. Eric, you said you try to retrieve it, but isn't it very difficult because there's no wire there? Normally, if you try to retrieve a stent, there's usually a wire through the
Yeah,
stent.
first you need to wire it. Yeah, of course.
So I'm
Yeah.
thinking, if you wire it, you don't really know where the wire is. Though, what if it's outside the stent? Or are you trying to just wire through the stent and then you can get your retrieval device through there? It's just you need the wire to retrieve.
Yeah. First you need to secure it with a wire. Yeah, for sure. Yeah. It's just an opinion, eh? Yeah. Inan, what do you think?
Yeah, I'm not able to see very clearly what's happening at the ostium of the left main. I think the stent at the ostium may be deformed.
Excuse me?
I know you drew that, but I can't see it.
Yeah, it's
So
difficult to say. Yeah.
I assume it's deformed right at the ostium of the left main. That's why the guide and nothing can go through. So when you have what I would do would be to try the wire and IVUS, making sure that the IVUS itself doesn't get stuck in the mangled stent right at the tip. Well, if it gets stuck, then maybe I'll try to. Not sure. It's a pretty tricky situation. Well,
One of the major problems was that there was a gelled wire and underdeployed left main stent. So that's two things, that combination that went wrong. When you have a gelled wire and then you post deal, it's probably the time to remove the gelled wire. It's questionable, but you have ostial left main stent. Port should be the first thing to do. Very good port, 4-0 port, etc. Because if you start with distal, your guide will interact with this stent. Plus, you have a gelled wire, meaning that whenever you pull something out of that, the guide will destroy the stent. Now, how we deal with that? Yes, you don't need probably to wire. You can wire it later, but you probably can snare it, try to grab something, and then pull it. Yeah, that's one of the possibilities. Then, of course, you can wire, you can do restent, you can do other things, but you can. It's fresh stent, it's under deployed. You probably can try to snare it.
Yeah, but it's a type A rule that first pot the proximal, and that in a left main stenting everybody. That's a first rule.
Yeah, but it wasn't potted.
I know, but it's a rule, but sometimes it is not done. But I think I will be accused of having a big delay, so I think we need to go on. Can you show us how you solved the problem? We are curious to see.
Okay. And we've tried to rewire with many moving, and luckily many times. And then we use the small balloon to test, and we saw that they maybe in the lumen. And then at that time, we instead we try from the small balloon to pick a balloon, even the scoring balloon, NC balloon, to open the vessel, and then we check the IVUS. This is the IVUS run after many balloons, and this is the IVUS run from only from the proximal of LAD to ostium of left main, and we see that there's some part we don't see any stent struck. Maybe it's come out with the pull back of the balloon. And please focus on the ostium of left main. At the ostium proximal and the ostium of left main, we see many layers of stent struck, and the stent is still inside the left main. We cannot do anything. We cannot get out. We just proceed. And at this point, with this picture, maybe what is your choice? We just I think that in at our position at that time, we have no choice. We just proceed with another stent. And so we use 40 by 22 on it to put from ostium of left main to proximal of LAD. and
What
then
is- yeah, there's
NC
something
balloon.
there.
And
That
this
section. Oops.
this the final angiogram, because we scale the catheter stuck inside the stent, so we pull back out of the osteums, and this is the final IVUS. In the final IVUS may grown very long, but you can see we will have many layers of stent, especially at the ostium of left main. And with the, please give me your advice with this final IVUS. What would you do? Just stop the procedure or do anything more?
Any question, comment? A long time DAPT, probably, yeah. A very long time DAPT.
Yes.
Yeah. DAPT for life.
Yes.
Any questions, ladies, gentlemen? Please.
Sorry, I was the same situation like him before, but I didn't do anything. I just left it because I understand that the wiring and more layers of stent in the left main is causing maybe the risk of thrombosis is too high for the patient. So my patient is in okay now, a few years after the stent dislodged in the left main. So it's my experience.
This is the final IVUS, and so we think that the story will not stop there. So we try to check the CAC 6 months later, just 2 weeks ago. This is the CAC.
Oh, so this is 2 weeks ago. It's recent, yeah. Okay.
And we see that there is maybe some new endothelialization at the ostium of the left main, and we don't know what happened. So we use the IVI to check. And here we have the this run from the only from the LAD. We have used the IVUS, and this time we have the OCT, and we check both. And this the LAD. We see that at the first bond, the proximal of the LAD, we will see that some endothelialization, some neo-intimo hyperplasia. The proximal of LAD.
Yeah.
And then for the left main, so sorry. Em cho hình hai hình chạy đi em, cho cả hai hình chạy.
So we just need to see the left main, yeah?
And please give me your opinion. What should we do next? What should we do next?
Okay, so this is done 2 weeks ago, and we need your advice.
The left main.
The angio is especially taking for you, for the audience. We need to have an advice so that the colleague can take
The patient
it.
still asymptomatic.
The patient is waiting for your answer, okay?
And
Please answer.
And when we measure the ostium of left main, the area is around 9.5, and the ostium, the proximal of LAD is around 9. So that's why we stopped the procedure, but we still have many concerns about this case. So we'll ask your opinion about this case.
So we can see there's no stent in the proximal LAD. Have no stent in material in the proximal LAD.
Yeah, we have stent on the proximal of LAD.
Yes, but we can see we don't see any stent drug in the proximal LAD.
I think that in the OCT, because maybe the some neo-intimo hyperplasia, so in the OCT the stent will not be clear, but we still see the stent struck on the proximal of the LAD. The proximal, yeah.
So it's probably very easy. Who would do something? Who would not just leave the patient?
Actually, it's
Raise your hands. Who would just leave the patient?
It's only 6 months, so you can only
Just
do
leave
two
it, yeah.
things. You either leave it alone and re-study in 6 months' time, okay, or you go and you actually do further ballooning. and you put a big drug coated balloon there, because it's going to be very aggressive. It's aggressive in 6 months. It's going to progress. So you can repeat again in 6 months time, and if it really is bad, then you may have to opt for open heart surgery.
Yeah.
Probably safer not. Probably safer not to do anything at this stage.
Yes. And so what I have learned in this case, first one, no pull back device forcefully when you get stuck. I think that in my case, instead of trying to pull back device for the balloon very strong, maybe try to boost and then try to pull back instead of just try to pull back, because at that time there's no big problem, because just there's something but we don't see because the core is not really heavy calcified, just some I don't think it's a big problem at that time, but when we pull back, the big problem after that. And so wire reservation is paramount in this scenario. So unfortunately, in this case, we lost the wire. And IVI, reverse velocity, is key to defining stent failure mechanism and optimizing follow-up. And we have some discussion question for you in this case, but we discussed already. And so thank you very much for your attention.